All the instructors. Dr. Saurabh Chaudhary will join us in a few moments, and Mukesh Sharma, he has got one instruction course. He will join us around 1 o'clock after he finishes his instruction course, where he's the chief instructor in another hall. So, slide please. Yes. So, in today's era of phaco, I think not to implant the IOL would be a big crime in a patient who has come to you for an uncomplicated cataract surgery. So what are the options we have to implant the IOL and to give good, useful vision to a patient who develops a posterior capsular rupture or zonal dehiscence during phacoemulsification? So the presenters will give their own ideas as to which IOL is best suited in which case. What I would like to show is, first of all, what are the steps or what are the things which we should take into consideration when we have this posterior capsular rent in a case of when we are doing phacoemulsification. And I'll be speaking about in the bag implantation like it never happened, the ideal place for implantation of a posterior chamber IOL despite a posterior capsular rent. I have no financial disclosures. Now, before we go on as to the rent itself, first we should know what cases are high risk for a PCR during phacoemulsification. Always take a history. If the patient gives a history of some complication in the first eye, if there's a PCR or some multiple procedure has been done, you should always be on the lookout that some complication might occur in this eye also. Of course, polar and subluxated cataracts, you have to be all the time on the lookout, because PC rent can occur at any step, even after the implantation of the IOL, which I'm going to show in my video also. Traumatic cataracts, you don't know what lies beneath, so you always should be on the lookout for some posterior capsule rent. Brown black cataracts usually have very floppy and thin posterior capsules, and obviously if you have an Argentinian flag sign, or if during the CCC it runs off to the periphery at any time due to the fluidic pressure, it might go up into the posterior capsule. So the first thing with which we should arm ourselves is the identification. We should learn to know when the PCR has occurred. The first step, and usually it is a pupillary distortion or a snap which occurs, and there is sudden give-way feeling. I have had this posterior capsular rent so many times that now I know exactly at what point or in what maneuver that rent occurred. And it usually gives a give-way feeling. And if you miss that pupillary distortion or a snap, what happens is afterwards there's a sudden deepening of the anterior chamber, because then the vitreous comes out of this rent. Then once vitreous is there in the anterior chamber, the fluidics gets altered, because whatever aspiration you are doing, the vitreous comes and blocks that port, and you are not able to have a free movement of the nuclear fragments. There's altered fluidics. From that area of rent, you see a bright glow, because there's no capsule and the vitreous is there, so that area of rent gives a very good red reflex. And obviously, even if you miss even that, the inevitable would occur. Either the nucleus would drop into the vitreous, or the cortical material will go into the vitreous. So what you should do, as soon as you see or you recognize that there's a rent, you have to stay calm. first thing. Now, whatever gives you that freedom from anxiety, you have to do that. Either you can blame your assistant or you cannot blame your assistant. It depends what gives you more control over your anxiety. Keep your phaco and IA or the IA handpiece inside the eye. Don't just withdraw every instrument in a knee-jerk reaction, because it will usually, the instrument will drag the vitreous along with it throughout the wound, and it will cause so much of traction to the vitreous. Now, you should gently inject a chondroitin sulfate based OVD. Why? Because it has a good coatability, and it will have a capsular bandage-like effect. It will block that area of rent. And before removing those instruments from the eye, you should disengage any vitreous strand which might be occluding those aspiration ports. And now you should withdraw these instruments of the eye. And at that time, you should now stop and take a deep breath, and you should think about what your strategy would be. Now, what you should assess is, first, how much nucleus or cortex is there still for you to clear up. What is the size and location of the rent? If whether the vitreous is frankly present in the chamber or not, and for that you can inject triamcinolone. And if there's anything, any nuclear fragment or cortex which has gone into the vitreous. After you have assessed all these, then you can initiate your steps. The first step is to, as atraumatically as possible, remove the nucleus and the cortex, for which you should always use a low flow, because vitreous is present. You should try to remove the vitreous and remove the nucleus and cortex as much as possible. And then you should identify how much vitreous is there in the anterior chamber by injecting triamcinolone, and then clear the vitreous from the anterior chamber and do a limited anterior vitrectomy also. You should try to minimize the trauma to the capsular bag, and then you should decide how much capsular support is there, and then you should implant the IOL, whichever is suited for that situation. So in the bag implant, in what cases would you still go ahead and do an in the bag implant if the rent is very small? Usually the rent in polar cataracts usually extends from one end to the other, and it is quite difficult to implant an IOL in the bag once the rent has occurred in a polar cataract. Always use a chondroitin sulfate based OVD, which gives a good support to that rent, and it blocks any vitreous from repeated coming out, and it doesn't come out as a bolus also. Then remove the nucleus and the cortex with low flow, which is very important. You should not use very high vacuum and flow rates. Unnecessary, it will hydrate the vitreous, and the vitreous will keep on coming out. Then there's a lot of talk about whether you should do a pars plana approach for vitrectomy or you should do an anterior approach. Dr. Samresh has shown in a very good video in which analogy of a cotton wool. If we pull that vitreous from the anterior part, it will just enlarge the rent. And if we pull the vitreous from posteriorly, it will not cause any enlargement of the rent. So you should always do a pars plana approach, and it is nowadays with a good sharp trocar cannula, it is so simple to just go through the pars plana and do a limited anterior vitrectomy with a 23 gauge vitrector. And then once everything has been cleared, you can convert that small tear into a PCC, and then you should implant the IOL, which is slow, and it unfolds very slow without a jerk. So for this, hydrophobic IOL are suited. Now, I have purposely chosen a video in which the rent has occurred at the point where the nucleus was present, so that all the steps are there. Even if you have a rent at the time of IA, everything is covered in this single frame. Now, first, the identification. of when that rent occurred. The first job goes well. Now just see, embedding it, and suddenly some giveaway is there, and this area of a bright glow is there. There the rent has occurred. And if you see carefully, there's a vitreous strand which has come here. At that time, you inject OVD, which is usually a chondroitin sulfate base. Now, once that viscoat has been injected, you see, while doing phaco, even these air bubbles won't move because it fills up the anterior chamber and it won't come out as a bolus. So you can vary with low flow parameters. The vacuum would hardly go beyond 100 or 150. The aspiration flow rate is 18. And very slowly we can remove all the nucleus. Obviously, this nucleus wasn't hard. Otherwise, it would have been a bit more difficult to remove. Once you have removed all the nucleus, now it is time to assess how much vitreous is there in the anterior chamber. For that, we need to inject triamcinolone. It is good to have a slit lamp on the operating microscope. It gives a good idea of how much vitreous strand is there. And if you inject triamcinolone, you can actually see those strands. And then do a pass-penna approach, limited anterior vitrectomy. Once this anterior vitrectomy is done, the IA can happen like in a usual case. You don't have to, the cortex is not admixed with the vitreous, so the IA feels as if nothing has happened. Once it has been cleared, now if you try to implant the lens at this point, this rent will further increase and the lens IOL will get destabilized. So you should convert this rent into a CCC so that the edges of this rent are strong enough to hold that IOL. You can see now this rent has been converted into a CCC, PCC. Now we can easily implant the IOL in the bag. Once the IOL is in the bag, you can again reconfirm whether there's any vitreous in the anterior chamber or not. And then clean any viscoelastic. The lens is well centered in the bag, and as if we did not have any complication of PCR. 2 weeks post-op, there is no CME. Now, this one small video I would like to share. This is a polar cataract in which everything went off very well till the time when the viscoelastic was being removed from behind the IOL. See, at that point, it happened somewhere here. Suddenly, the posterior capsule came into the irrigation handpiece, and as what I was saying is, if you injure the posterior capsule in a polar cataract, it will extend all the way from one end to the other. And this was a multifocal IOL. Now, even I thought that I would get away with it. I hydrated the wounds, but you see what is happening. The lens is tilting on one side. And this is not the ideal situation. Now, to deal with that, we have to, again, identify how much vitreous is there, and you have to remove this vitreous here. Only then the IOL will stabilize. So with a pass-penna approach, we remove first the vitreous which was there behind, and the small strands which were there in the anterior chamber. Now you see, despite the rent, the IOL is well centered. Even after, this is intraop, day 1, day 7, and the IOL is well centered, and as you can see. So we can deal with any situation as if this complication hadn't occurred at all.